Hi everyone, I'm Dr. Sai Sangeetha, henceforth referred to as Puppy.
Hi everyone, I'm Dr. Arpit Shantagiri, henceforth referred to as Oppie. Hi, good to see you again.
I guess you couldn't wait to see me after the first date.
Yeah. I have got a problem for you to solve.
What's it about?
Jaw tumors. So many lesions jumbled up on such a small space. Could you help me with it?
Yeah, sure. I have got it simplified. Let's start.
Hi guys, let's teach Api starting from the basic anatomy of the mandible, followed by approach to jaw tumors, and we'll end with the classification of jaw tumors. Starting with the anatomy, this is the angle of the mandible. Above this is called the ramus of the mandible, and below this is called the body of the mandible. The body of the mandible is further divided into the base of the mandible and the alveolar processes. The ramus of the mandible ends in a mandibular condyle, which in turn articulates with the temporal bone, forming temporomandibular joint. There is an important nerve known as inferior alveolar nerve, which is a branch of V3 division of trigeminal nerve. V3 division is nothing but the mandibular division of trigeminal nerve. This dotted line here is inferior alveolar canal, through which the inferior alveolar nerve passes. The inferior alveolar nerve enters via the mandibular foramen and exits via the mental foramen. Now, any lesion which is present above the inferior alveolar canal, the lesion above it, I mean to say the epicenter above the inferior alveolar canal. So, these lesions are called as odontogenic lesions, and the lesions having epicenter below the inferior alveolar canal are called as non-odontogenic lesions. So, what do we mean by odontogenic? Any lesion which is having its origin from the tissues of the tooth are called as odontogenic lesions. Now, we'll look at other differences between odontogenic and non-odontogenic lesions. So, if the lesion is associated with just one tooth, it is most likely an odontogenic lesion. If it is associated with two or more teeth, it is a non-odontogenic lesions. Moving to the anatomy of the tooth. It is divided into the crown, the neck and the root, which internally is divided into the enamel, the dentine, the pulp, which is surrounded by the cementum, which is sitting in the inferior alveolar processes of the mandible. Now we'll look at the various radiological modalities available to assess jaw tumors. Starting with the OPG, OPG is the first line of investigation. CBCT is something which is done by the dentist himself, which gives 3D anatomy of the bone. Then we have MDCT, which the radiologist does, and it is considered the investigation of choice. And contrast enhanced CT is a must and should to evaluate the soft tissue component, as well as it also gives information of the bone, and hence it becomes the investigation of choice. MRI is just a problem solving tool. Now we'll answer the second most important question, that is the difference between a benign jaw tumor and a malignant lesion. Starting with the OPG. On an OPG, if you're seeing a well-defined lesion and the tooth are normal or either displaced, it is likely a benign lesion. However, if it is an ill-defined lesion, the tooth are either lost or completely resorbed, then it is likely a malignant lesion. Now we look at an example. So this is a first case scenario where we can see that the tooth here are normal and in these two teeth are slightly displaced. So likely we are dealing with a benign lesion. And in this scenario, we can see that the tooth here are lost. So we are likely dealing with a malignant lesion. Now we look at the CT differences. On CT, if the cortex is well maintained and there is no enhancing soft tissue component, we are likely dealing with a benign lesion. However, if there is a cortical destruction and there is an enhancing soft tissue, we are likely dealing with a malignant lesion. Now we look at the example of it. We can see that here the cortex is well maintained and there is no enhancing soft tissue component. Here we can see that there is breach in the cortex with an enhancing soft tissue component. Hence, this is a malignant lesion and this is a benign lesion. Now that we understood how to differentiate between benign and malignant lesions, we look at the most important part of today's lecture, that is how do we approach jaw tumors. Always and always and always start with an OPG and classify them as radiolucent, mixed and radiodense lesions. Once you do that, half of your work is done. Then you have to differentiate whether it's a odontogenic or a non-odontogenic lesion. I've already explained you how to differentiate. If the lesion having an epicenter above the inferior alveolar canal, it is an odontogenic. Below the inferior alveolar canal, it is a non-odontogenic lesion. And then once we understand this, then we consider each of them. If it is an odontogenic, again classify them as benign or malignant. Again, non-odontogenic, classify them as benign versus malignant. After you do this much on an OPG, you confirm the findings on CECT. I've already explained it just 2 minutes ago, how to differentiate between a benign versus malignant on a CT. Now we look at the classification of jaw tumors. I've already told you that jaw tumors are classified based on OPG into radiolucent, mixed and a radio-opaque lesions. Starting with the radiolucent lesion, every radiolucent lesion will be divided into odontogenic and non-odontogenic. And as a general broad rule, remember that odontogenic lesions are usually benign lesions, non-odontogenic lesions are usually malignant lesions. So we'll look further. So odontogenic lesions, most of them are benign lesions, so they'll have a well-defined border like radicular cyst, dentigerous cyst and OKC. However, ameloblastoma will have ill-defined borders and hence it is a borderline malignant to a malignant lesion. Now we look at the example of it. So we can see here that we have a OPG which is showing a radiolucent lesion having an epicenter above the inferior alveolar canal, hence it is a odontogenic lesion. Most of the odontogenic lesions are benign lesions and this is having a well-defined margins. So it is a benign lesion. So it is one of the three, that is radicular, dentigerous or an OKC. How do we differentiate between these three? We'll learn it in the next chapter. Now we'll go to the second set, that is the radiolucent non-odontogenic lesions. The non-odontogenic lesions are further classified into benign and malignant. The benign lesions will have well-defined margins, whereas the malignant will have ill-defined margins. Among the well-defined margins, that is the benign lesions, we have 7 lesions, that is CGCG, hemangioma, Brown's tumor, Staphylococcus cyst, nasopalatine cyst, nasolabial cyst, finally cherubism. Among the ill-defined margins, that is the malignant lesions, we have similar to the Bones tumor, that is the Mets, myeloma, lymphoma, primary bone tumors like Ewing sarcoma, osteosarcoma, chondrosarcoma, and most importantly, the Langerhans cell histiocytosis coming with a floating tooth appearance on an OPG. Now we are done with the radiolucent lesions. We'll move forward to the mixed lesions. The mixed jaw tumors, as I've already told, we divide them into odontogenic and non-odontogenic lesions. Odontogenic are usually benign lesions, that is, we have 3 under this category, that is odontogenic myxoma, Penbock tumor and cemento-osseous dysplasia. Coming to the non-odontogenic lesions, we classify them based on whether it is having a narrow zone of transition or a wide zone of transition. From Bones tumor knowledge, we know that narrow zone of transition is usually a benign lesion and wide will have a aggressive lesion or a malignant lesion. So among the narrow zone of transition, we have fibro-osseous lesions. That is, we have fibrous dysplasia and an ossifying fibroma. Fibrous dysplasia, we already know that it is an expansile lesion with a ground glass matrix. However, we are seeing the same features, but in addition to it, you have a calcification with it. You call it a ossifying fibroma. Coming to the wide zone of transition. Wide zone of transition, by default, we know that it is most like an aggressive lesion. So, similar to that of a osteosarcoma. So, we can see here that this is a mixed density lesion having few areas showing lucency, few areas of sclerosis, and you can see a lot of sunburst type of a periosteal reaction, which is very, very classic of a osteosarcoma. But there are few mimics of an osteosarcoma which can come with a wide zone of transition. And these two are very, very important spotters. That is the osteoradionecrosis of jaw and chronic osteomyelitis. How do we differentiate this from a classic osteosarcoma? So, the osteoradionecrosis of jaw will have a history of radiotherapy, and you will see similar to osteosarcoma, you'll have there are areas of sclerosis, there are areas of lucence, but there is no enhancing soft tissue component associated with it. And the classic history should point you the diagnosis of osteoradionecrosis of jaw. Next, coming to chronic osteomyelitis. Again, you'll have a history of a patient coming to you with a toothache, and then you will see that chronic osteomyelitis typically will have a sequestrum, you'll have a involucrum followed by a cloaca, and if you see in soft tissue window, you'll have an associated collection. And these two are considered the mimics of osteosarcoma. The two important diagnoses, that is osteoradionecrosis of jaw and chronic osteomyelitis. Now we are done with the mixed jaw tumors. We are finally left with the radio-opaque lesions. Radio-opaque lesions, again we classify them into odontogenic and non-odontogenic lesions. Non-odontogenic lesions follow WHO classification of bone tumors, whereas odontogenic lesions are just two in number, that is cementoblastoma and odontoma. Now we are done with the classification of jaw tumors. We'll study about each lesion in detail from now for the next 15 minutes. We'll start with the radiolucent lesions. So, radiolucent lesions we have already studied. We classify them as odontogenic and non-odontogenic lesions. Under odontogenic lesions, we further classify them as the lesions with well-defined margins and OPG. They are three in number. That is the radicular cyst, the dentigerous cyst, and OKC. OKC is also known as odontogenic keratocyst. Starting with the radicular cyst. See, the radicular cyst is typically seen between the age of 20 to 40 years, and it is associated with dental caries, and it is most commonly located in the posterior mandible. So on OPG, we already know that it is a radiolucent lesion, right? And it is odontogenic. It is going to have well-defined margins. We already know this. What makes it a radicular cyst is that it is typically present below a dead tooth. We can see in this example also that this is a dead tooth, and we can see a well-defined cyst sitting below this dead tooth. On CT, we will not see any enhancing soft tissue component. Moving to our next lesion, that is dentigerous cyst. It is typically seen between 10 to 20 years of age. It is developmental in etiology, and it is most commonly located in the posterior mandible. Now, we already know dentigerous cyst is also a radiolucent cyst. It is odontogenic, it has well-defined margins, and what makes it a dentigerous cyst is that it is pericoronal in location, meaning to tell it is located above the impacted tooth. That typically makes it a dentigerous cyst. On CT, again it's just a simple cyst without any enhancing soft tissue. Coming to our third lesion in the category, that is OKC. OKC is typically seen in the age group of 20 to 40 years. When there are multiple OKCs within the mandible and maxilla, you should think of Gorlin syndrome. Very, very important. You should think of Gorlin syndrome, and it is a spotter which is repeatedly asked in our exams. It is located most commonly in the posterior mandible. Coming to the OPG findings, we already know again that it is a radiolucent cyst, odontogenic, it has well-defined margins. What makes it an OKC is that it is a multilocular cyst. So we can see that this is a multilocular cyst, right? And it displaces the tooth. It doesn't cause tooth loss or erosion, it just displaces the tooth. That is what makes it an OKC. And on CT, the most important point is that the transverse diameter is more than the AP diameter, and since it is a benign lesion, we already know that the cortical margins will be well maintained, and we know that there won't be any enhancing soft tissue component. In contrary to ameloblastoma, when we see here in ameloblastoma, the AP diameter will be more than the transverse diameter, and you can see that it has an enhancing soft tissue component with a cortical breach because it is a borderline malignant to malignant tumor based on the grading, right? And then now we start with the ameloblastoma. Ameloblastoma comes under the classification of a radiolucent lesion on OPG, which is odontogenic but it has ill-defined margins, right? And it is typically seen in an elderly patient, most commonly located in the posterior mandible. On OPG, you will see a classic soap bubble appearance. This is again a spotter and a long case also in our practicals. You will see a typical soap bubble appearance where you can see this multiloculated cystic lesion with coarse trabeculations, and you can see typically there is loss of tooth. This is an ameloblastoma, and we have already discussed the CT findings as comparison to OKC, right? Now, we are done with the first set, that is a radiolucent odontogenic lesions. Now we'll move forward to radiolucent non-odontogenic lesions. Again, I've explained radiolucent non-odontogenic lesions are further classified as those having well-defined margins and those having ill-defined margins. Those having well-defined margins are likely benign, and there are 7 in number, that is CGCG, central giant cell granuloma. Secondly, you have Brown's tumor. Third, hemangioma. Then the next set of 3 goes to Staphnase cyst, nasopalatine cyst, nasolabial cyst. And finally, you have cherubism. So we'll start with the first one, that is CGCG. So it is typically seen in a young adult around 10 to 20 years and comes with a classic history. What is the history? That is, it has a painful swelling with a bleed. This history is very typical, and the next most important point about CGCG is that it is located in the anterior mandible crossing the midline. Guys, you have to remember the most important question of jaw tumors, that is, what are the lesions involving the anterior part of the mandible? Very important question. So CGCG is one thing which is involving the anterior part of the mandible. On an OPG, we'll again see that it is a multiloculated cystic lesion. However, you can see there are fine trabeculae within it. However, once we go to the CT, what do we see? We see on contrast, moderate to intense post-contrast enhancement, and it has a very unique feature which is repeatedly asked in our exams, that is on MRI it's a T2 dark lesion which is another bone tumor which is T2 dark, that is giant cell tumor. Very important question. Now we are done with CGCG. The second lesion we discussed was Brown's tumor. Brown's tumor and CGCG will have similar imaging appearances. The only difference between both of them is the history, right? So next we go to a third lesion, that is hemangioma. Hemangioma, intraosseous hemangiomas are typically seen in a middle-aged to elderly patient, and then it is most commonly involving the anterior mandible. So we have 3 lesions involving the anterior mandible now: CGCG, Brown's tumor, hemangioma. And on OPG, again you will see a multiloculated cystic lesion with coarse trabeculations. CGCG had fine trabeculations. Hemangioma will have coarse trabeculations. And like a typical hemangioma, this also shows intense post-contrast enhancement on CT. Right? Now we'll go to the next set of 3, that is the Staphnase cyst, nasopalatine cyst, and nasolabial cyst. Starting with the Staphnase cyst. Staphnase cyst, the location is very typical about it, right? It is present typically below the third molar, and we already know it is a radiolucent lesion. It is non-odontogenic, that is, it is below the inferior alveolar canal, right? So we don't have to discuss much about the OPG. We can see here already that This is a well-defined cystic lesion which is radiolucent, typically located below the inferior alveolar canal and the third molar. The important thing is on CT you can see that there is loss of this buccal bone which is replaced by either fat or submandibular gland, and Staphnine cyst is a usual spotter. Now we come to the nasolabial cyst versus nasopalatine cyst. Both are simple cysts. How do we differentiate? Nasolabial cyst is typically laterally located, whereas nasopalatine cyst is in the midline. So nasopalatine cyst is basically in the location of incisive foramen, which is at the tip of the maxilla, right? Then we come to the last lesion in this category, that is cherubism. Cherubism is a type of a fibrous dysplasia which is most commonly seen in children. On an OPG, we can see that it is an expansile lytic lesion involving both the mandible and the maxilla except the mandibular condyle. This is very important. It is except the mandibular condyle, right? Now we are done with this set of lesions, that is radiolucent, non-odontogenic with well-defined margins. The radiolucent, non-odontogenic with ill-defined margins are basically the malignant bone tumors which will follow WHO classification of bone tumors. You can apply the same rules and diagnose them, right? Now we go to mixed jaw tumors. So, coming to the mixed jaw tumors, again, they are further divided into odontogenic and non-odontogenic. The non-odontogenic were further classified as narrow zone of transition and wide zone of transition, and we have discussed that set already in the classification. So, what we were left with was odontogenic tumors. And I told you, odontogenic tumors in mixed jaw tumors were all benign lesions. And there were 3 in number, that is odontogenic myxoma, Pinbock tumor, cemento-osseous dysplasia. So, starting with the first one, that is odontogenic myxoma. Odontogenic myxoma is seen in a 20 to 30-year-old person located in the ramus and the posterior mandible. On an OPG, it is very important you get a tennis racket appearance. What do we see? A tennis racket appearance. Why do we call this a tennis racket appearance? So, we can see that here it is again a multiloculated lesion, right, with coarse trabeculations. Here you can see there's a foci of sclerosis, right? This whole thing is a multiloculated cystic lesion, so it became a mixed lesion. And then we can see there are multiple coarse trabeculations giving a tennis racket appearance, right? So you can see this, remember this lesion, you will see a tennis racket appearance. And then now coming to CT and MR. CT and MR will have myxomatous appearance. What do I mean by myxomatous appearance? Any myxomatous tissue anywhere in the body on CT will give you a fluid attenuation. On MR, T2 sequence, it will show an intense bright signal similar to that of on water. However, on contrast, both of them, CT and MR, will show delayed, minimal to mild post-contrast enhancement. This is a typical appearance of a myxomatous tissue anywhere in the body, right? Now we'll go to the second lesion, that is Pinbock tumor. Pinbock tumor is also known as calcifying epithelial odontogenic tumor seen in an elderly, most commonly located in the posterior mandible and the ramus. What is important is on an OPG, you will see that it has a driven snow calcification appearance. This is again a spotter, driven snow calcification appearance, and it is typically pericoronal in location. That is, it is located above an impacted tooth. Now we come to the last lesion in this category, that is cemento-osseous dysplasia, typically located in the anterior mandible. I told you any lesion in the anterior mandible is important. It's a repeated spotter. On OPG, you will see a well-defined lytic lesion with central calcification. This is what you'll see even on CT. You'll see a lytic lesion with central calcification, right? This is a repeated spotter. Now we are done with mixed jaw tumors. We are left with the last topic, that is radio-opaque lesions, right? So, the radio-opaque lesions are again classified as odontogenic and non-odontogenic. Non-odontogenic, I already told you, it follows WHO classification of bone tumors. Now, radio-opaque lesions which are odontogenic were just 2 in number, that is cementoblastoma and odontoma. The only difference between cementoblastoma and odontoma is that, see, cementoblastoma is a sclerotic lesion with a lucent rim which is located at the root of the tooth, whereas odontoma is again a sclerotic lesion with a lucent halo which is located pericoronal in location, that is above the impacted tooth, right? So the only location is the difference between cementoblastoma and odontoma. And if there are multiple odontomas, you should always suspect Gardner's syndrome. Gardner syndrome is associated with familial adenomatous polyposis, the colon polyposis syndromes, right? FAP. Now that we've completed the classification of jaw tumors, we've understood in detail about each of the lesions of jaw tumors. Now we'll just take a small quiz to understand how much have we understood, and these are few important spotters come questions which are routinely asked in your vivas, right? So this is the first case scenario. If anyone could get an answer, it's very good. We'll discuss about this now. We can see that it's a OPG we are having. This is a radiolucent lesion. After we decide that, we have to decide whether it's a odontogenic versus non-odontogenic. This is our IAC. The epicenter is above it, so it is a odontogenic lesion. Then we need to decide, is it a benign versus malignant. We can see that there is no loss of the tooth anywhere, right? And it's well-defined lesion, so this is benign lesion. So we have 3 lesions under this category, that is, the first is radicular cyst, dentigerous and OPC. Because it is sitting above the impacted tooth, this becomes a dentigerous cyst. Here we can see the second lesion, which is a multiloculated cystic lesion having well-defined margins. So this becomes a OKC. And here we can see there is one more multiloculated cystic lesion which is well defined, radiolucent. This is another OKC. And what did I tell you guys? Whenever you're seeing multiple OKCs, think of Gorlin syndrome. This is how the spotter comes in the exam, and then you have to answer it as a Gorlin syndrome. Now, this is the most commonly asked question in vivas whenever you get mandible as a long case. What are the lesions most commonly involving the anterior mandible? So we've already read the set of 3, that is CG, Brown's tumor, we have hemangioma, and then the last one, cemento osseous dysplasia. Right? This is a very important question. Now, the next question they ask you guys is, which are the lesions which are pericoronal in location and which are periapical in location? Remember this, all jaw tumors are periapical in location except 3 of them, one from each set of radiolucent, mixed and radiodense. So from the radiolucent lesion we have dentigerous cyst, from the mixed lesion we have Pinbock's tumor, and from the sclerotic lesion we have odontoma. So this is the end of our lecture on jaw tumors, guys.
Thanks. You made complex things simpler.
That's what I do.
Since we are done, let's take a breather with a breezer, shall we?
J-Lo.
Hey,
Hey guys, if you like our simplified approach to difficult conceptual topics, please do comment, like, share, and subscribe to our channel.